Okay, perfect. So let's do another one. Let's do tachycardia. Okay. Awesome. So this is another one, you get paged. This, by the way, this one I hate getting this page. Patient X is tachycardic. It's tachy. Okay. And then, you really have to deal with it, because if somebody is tachy for a long period of time, they might develop, again, it might be a sign of sepsis as all these clinical changes, or it might not, okay? So a lot of times, these patients who are tachy, or they become tachycardic, they're usually on telemetry, okay? Which means that the nurse is monitoring and the thing is beeping, and it usually beeps when the heart rate is above 100. And then that's why the nurse pages you, because patient is tachycardic. Now, if patient is not on telemetry, what are you gonna do? You're gonna place them. Place the patient on telemetry, which means you're gonna connect the patient up to the monitor, and then they're gonna be monitored from the patient's from the nursing station. Okay. So that's really important for you to remember. Okay. So, you get the call, patient is tachycardic. What are you gonna do first? You're gonna assess the patient. Okay. You're gonna go physically and you're gonna assess the patient. All right. What are you gonna assess exactly? Let's say the patient is on tele. I would urge you to go assess the tele. What does this mean? What does assess the tele mean? It means you're going to go to the monitor where the patient is being recorded, and then you're going to see the rhythm on the actual monitor. Okay, so you're gonna look at the monitor, and then you're gonna see the whatever rhythm the patient is on. And also, I mean, usually there's like buttons, and you can go back in time, and then you can see kind of what happened to this rhythm. Like, few things you can see. First thing you can see is, when did it start? Like any other chief complaint, when did it start? And specifically, you're going to look at the transition point, okay, between the normal rhythm and the abnormal rhythm, okay, and the tachyarrhythmia, right? We call it a tachyarrhythmia. And then number two, so this is number one. Number two, you're going to diagnose the rhythm. You're going to diagnose what kind of rhythm they're on. Okay. So what kind of things are you going to diagnose based on the rhythm? What are the common things that you're going to see? What do you think? What's the most common one that you're going to end up seeing?
Afib.
SVT, Afib. Okay, great. So first one is Afib. It's not just Afib, it's Afib with RVR. RVR means rapid ventricular response. It means the rhythm, the ventricle is overbeating because it's oversensing the Afib wave. The other one could be an A flutter, usually with 1 to 2 conduction. Okay, remember this will be SMAC 150. The rhythm will be 150. It will be just beeping at 150. Okay, very easy to diagnose, very easy to miss. Okay, what else? SVT. So somebody mentioned it could be SVT, supraventricular tachycardia. It could be VT, Vtec. Okay, it could be the other one, multifocal atrial tachycardia. You know this one? This one is the COPD.
Mostly COPD one.
Yeah, multifocal. Okay, and then other than SVT, it could be AVRT. Could be AVNRT. These are the other supraventricular or nodal tachycardias. Okay. And then finally, the most common is what? Sinus tachycardia. Okay? So just to revise with you real quick, really quick. AFib and aflutter, how are you going to treat them? Beta blocker, right? You can do beta blocker. And the one in choice, you just kind of have to memorize it or know it. I usually, this is the standard, is to give something like 5 milligrams of IV lopressor. Lopressor is the trade name for metoprolol. This is metoprolol tartrates, the short acting. Okay. And then if that doesn't work, alternatively, you can give diltiazem. If that doesn't work, you can alternatively give what? Digoxin. If that doesn't work, you can give amio. Okay. So these things are like kind of things that you can think about. How about SVT? How do you treat SVT?
Carotid massage.
Right. So carotid massage, vagal maneuvers, right? Or medically, what do you give? Adenosine. And then remember, adenosine you can give 6, 12, maybe another 12 if it doesn't work. And then finally, what can you do if nothing works? You can do beta blockers or you can shock. Okay. How about Vtec? If you see Vtec on the monitor. Problem, right? This is big emergency. If you see Vtec on the monitor, it means you really have to, you have to act fast. And this is one of the few situations where I would think about, calling an RRT right away. Okay? Because you might need to shock. MAT, you just deal with the hypoxia. So you just give, essentially you give O2, you treat the hypoxia. And then sinus tach, how about sinus tach? You got to look for underlying cause. Right? The sinus tach, most of the time, is a physiologic response that you want to look for a cause for it. Okay? Now, you diagnosed the rhythm, you looked at the tele. We'll talk more about it, but you assess the patient. What are you guys going to assess with the patient? What's the most important thing you're going to assess with the patient?
Blood pressure.
Blood pressure. Perfect. Yes. You're going to assess the blood pressure. And if the blood pressure is low, what do you call this? This is
cardiogenic shock or unstable patient.
Unstable tachycardia. Okay. Now this can be wide complex. It can be narrow complex. Regardless, if it's unstable tachycardia, most of the time you're going to shock. This is like kind of in your mind, that if it's unstable, you're going to end up shocking because you're going to assume that the tachycardia is causing the instability of the patient. Okay. If the blood pressure is normal, if you see the blood pressure is normal, then you have to kind of, I'm just going to write C below. These things. Okay. So all these things you're going to do. Okay. So it's kind of very simple, right? In terms of sinus tachycardia, by the way. So what causes of sinus tachycardia? What are the things that you just gonna have to think right away?
Fever, pain.
Okay, fever. What about fever? Do you know how much do you expect the heart rate to be?
With each degree, 10 extra 10 extra 10 beats.
You increase 10 beats per minute. Exactly. Okay, good. And then somebody mentioned, very important, never miss a PE. Okay. Bleeding. These patients will have bleeding. Very important. Okay. Another one, pain, anxiety, these things, or like some whatever psych condition. Okay. Another one you will see here, you don't think about it a lot, is withdrawal. Withdrawal from, from drugs, withdrawals from alcohol. These things will cause tachycardia, sinus tachycardia. Another one also we don't think about. Somebody shows up to the hospital, has a history of heart failure, and then they become tachycardic in the hospital. What things you might think about? What do you think?
Hyperthyroidism.
Hyperthyroidism, okay, but these things don't happen in the hospital. These people are like chronically, probably chronic. It's something that we don't usually think about, but it's beta blocker withdrawal. People with beta blockers, they have upregulated beta receptors, and when you stop the beta blocker, they get rebound tachycardia. So rebound tachycardia, beta blocker withdrawal is something to consider. Then you think of the others like hyperthyroidism, whatever, like all these other things that might be. So depending on the cause, you're gonna treat, but really here the important thing is, never miss a PE. Okay, that's like really the important thing. Now, remember we talked about Vtec. I'm just gonna expand a little bit about Vtec because really that's the most important one you need to know. So regarding Vtec, or one of the most important ones, Afib with RVR is another important one. But regarding Vtec, because you're gonna have to act quickly, first of all, when you think about Vtec, you have to think of something very specific, okay? Because Vtec is not always like the exam question is just given to you. But usually what you want to think about is something that is wide complex. So any wide complex that you see, plus tachycardia. Okay, you don't need to prove that there is a Vtec, but there's some things on the EKG that might give you that this Vtec. One of the things is a retrograde P wave. Okay, which means you see the QRS and then you see a little P wave after the QRS. Okay, that might be an indicator that this is actually Vtec. Okay, and there's another kind of, it's a pimping question. There is another rhythm that is not Vtec that will give you wide complex tachycardia. Do you know what it is?
Sometimes SVT.
SVT alone, no. It's going to be narrow complex. But it's usually if there is, not really SVT, if there's Afib and there is an accessory pathway, there is an aberrant pathway. So the aberrant pathway might take control and it will cause a wider complex. So Afib with RVR with aberrancy is what they call it, might cause a wide complex tachycardia. And the treatment of this one is treatment of Afib, the same way as you treat Afib with RVR. Okay, but for all intents and purposes, when you see wide complex tachycardia, you're gonna look at the rhythm. Okay, and when you look at the rhythm, there's gonna be two big rhythms you need to know, right? It's either this one or so what's the difference? What do you call this one? What do you call that one?
Monomorphic and polymorphic
Nice.
ventricular tachycardia.
So, exactly. So monomorphic and then polymorphic. Okay. Why do I care? Why do I care? Do you know?
Because of the underlying cause.
No. You care because of the way you treat either of them. Both of these ones can be treated with shock. Okay. But the shock for monomorphic is synchronized, while the shock for polymorphic is unsynchronized. Okay. Shuyani, what does synchronize mean? Synchronize mean that you will sync the shock. So you will capture these R waves and then you will sync the shock to shock on an R wave, not on a T wave. Because if you shock while the heart is repolarized, you will induce VFib. While with polymorphic, you can't really sync, so you just give anytime. Okay? So the most important thing when you have Vtec, before you even think about it, once you diagnose Vtec, is to go assess the patient and to see, is there pulse or is pulseless? If it's pulseless, then what do?
CPR.
CPR and you shock. Okay. And then, you're gonna code blue. Okay, you're gonna call a code blue for this patient. Well, if there's a pulse, how can you treat them? So you can shock them to get them out of the rhythm, especially if they're unstable, which means low blood pressure. Even if there's a pulse. When there's no pulse, usually there's no blood pressure. But if there's a pulse, if the blood pressure is weak, you want to get them out of the rhythm quickly, as we said in the beginning, But if there is pulse and the blood pressure is not low, what can you do? Easy. When you have an arrhythmia and you don't know the answer, you know what the answer is?
Amiodarone.
Amiodarone, the savior. Okay, amiodarone. So you're gonna load them with amiodarone, and you're gonna give them like 150 milligrams of IV amiodarone. Okay, and then start them on a drip. Okay, so that's what usually happens. And then what usually happens is you want to do an EKG right away to confirm, and then you're gonna send troponins. And then the rest of the labs, workup, whatever you want to do. And then consult cardiology, because this is not a normal thing that somebody has Vtec, okay? Because eventually they will need to be, monitored. They might need a life vest. They might need an ICD. Something is going on. You need to figure out why they had a Vtec. Your job as the intern is to dwell quickly to, I just want to treat it. I want to finish it. I want to do the right thing. Then morning team later, I'll deal with the big thing later. But for now, I just want to I don't want to make the patient survive. Okay. That's all you're kind of focused about. Okay. And that's kind of pretty much it. That's tachycardia in a nutshell. I mean, if you know these, you'll be fine. Once you get into Afib RVR, you might have a lot of other things that you need to know. You guys have any questions? All right, awesome. So I think we're gonna end for today. I hope you guys kind of benefited from this. Again, as usual, I mean,